Welcome and thank you for coming to the webinar series from the Eye and Ear Foundation called Sight and Sound Bites. This is a bi-weekly webinar series that highlights research at the University of Pittsburgh School of Medicine. I'm Craig Smith. I'm a development officer with the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support, and we want to thank any donors who may be on, and thank you for the support that you provided. A few housekeeping rules for today's webinar. You'll notice that chat is disabled, so you won't be able to chat during today's webinar. However, please feel free to use the Q&A function to submit questions. You can submit questions about the presentation throughout the entire hour, and then after the presentation, we'll leave about 15 or 20 minutes to go over those questions. We do ask that you refrain from asking any very personal medical questions that might not be relevant to the larger group. You can please feel free to send those, but we will not answer those live during the webinar, but we will be able to follow up with you personally through email to try to get answers to those questions. And then we also have subtitles available, so please feel free to use subtitles with closed captioning. And we want to let you know that we will be adding everybody that attends today's webinar to our mailing list, and we'll also be emailing out a video recording of today's webinar in case you want to rewatch it or share it with any friends or family or interested parties. So today's webinar is entitled Everything You Want to Know About Keratoconus. We are joined by two of our esteemed faculty members, Dr. Gaurav Prakash and Dr. Vishal Jhanji. Dr. Prakash is an assistant professor of ophthalmology at the University of Pittsburgh School of Medicine. He completed his ophthalmology training and corneal fellowship from the prestigious All India Institute of Medical Sciences in New Delhi, India. He is a clinician scientist with vast experience in the field of corneal disorders and refractive surgery and specializes in keratoconus and corneal ectasia. His focus of clinical and research work includes early detection of keratoconus and management using treatments such as cross-linking and corneal transplants. Dr. Vishal Jhanji is a professor of ophthalmology at the University of Pittsburgh School of Medicine. He's a corneal specialist and a clinician scientist by training. Dr. Jhanji completed his ophthalmology training from the prestigious All India Institute of Medical Sciences in New Delhi, India as well, and his fellowship from the Royal Victorian Eye and Ear Hospital at the University of Melbourne in Australia. Dr. Jhanji joined as a professor at the University of Pittsburgh in 2017, and he's also the current president of the Eye and Contact Lens Association. So at this time, I'd like to turn it over to Dr. Prakash to start today's presentation. Dr. Prakash.
Thanks, Craig. Thank you, everyone, for joining us. So we'll be talking a bit about keratoconus, and basically, it's going to be things we have always thought about asking, but we don't know how to ask those questions. So I'll be talking about the first part, and then Dr. Jhanji will talk about the future directions. I would start with a story. We all love stories, right? So this is the story of despair and hope put together in a unique situation. Now, this is the story of a young person who comes to us, and we see this very commonly, who is a young 19-year-old person who has frequent headaches, cannot drive in the dark, and barely manages his day throughout the day. His glass prescriptions are becoming worse every 6 months, and nobody has an answer. Now, this is more common than we think. Now, before we go there, let's look at what he's seeing. So, the upper two slides show how you see with your glasses, assuming that you have normal vision and you don't have the disease he has. In a normal to low prescription, you will see things a bit more blurry, a bit more hazy. A high prescription makes it tough, but you can still manage and see what's happening. And the lower two are how our friend sees. The early disease, in which you see some doubling, haziness, and by the time the disease becomes more advanced, even with glasses, there's no meaningful vision. So he can still see what's in the room, but he cannot make his work through. And this is very, very common with this particular disorder. So let's talk about what he has. So he has this disease called as keratoconus, which in more simpler terms is called as the conical cornea. It's a Greek word. Keratos means horn and conus means cone. This disease can affect from 1 in 150 to 1 in 1,000 people based on which part of the world you belong to and what's your demographics and your family history. So in a population of, say, around 300,000 people in a modern suburban society, probably 1,000 people will have this disease, which is a very large number. How does it present? So it typically starts when you are young. earlier cases in some risk factors. You have had patients who have got age of 6 years and 7 years diagnosed with keratoconus, but mostly it's the early teens to the late, from the mid-teens to the early adulthood when the disease manifests. A young adult with frequent change of glasses is a pretty big red flag over here. Somebody who's 22, 23 should not have change in glasses. They should have stabilized. And they're not doing, there's a reason. As I told, the incidence can be very high in some demographic pockets. A very significant or a very sensitive sign is that the night vision tends to get worse faster than the day vision. These patients can still, unfortunately, manage well in the day, but when the sun sets down or it's early in the morning and driving to work, your night vision is significantly worse. 20% of cases have a family history. And the worst part with this is that sometimes it could be progressive, which could be relentless, that it can go to a point when none of the glasses stop work for these patients. So you want to make sure that you pick it up early and treat it early. Before we go there, let's talk about a bit of basics about how the eye looks, so to give us a better understanding. The cornea, or the front part of the eye, is the window of the eye. It's like the windshield of a car. If that windshield is distorted, whatever you do, you're not able to see well from that. The normal cornea actually looks like a soccer ball. However, in keratoconus, what happens is that the soccer ball tends to bulge like a football. And you can see over here, this bulging, the arrows have marked, is the area of the pathology. This is irregular and this is bulging, protruding forward. And therefore, whatever glasses you give will not be able to help through this because the image being formed is very irregular. So remember this again, that a normal cornea looks like a soccer ball and American football over here. Now, why does this happen? This happens because the cornea has something called as collagen. Basically, think of this as fibrils or connections which hold the cornea together, like rest of the body, like rest of the skin. Right? These collagen fibers are supposed to be tightly wound to each other, and pretty much like the image on the left of the screen, when you see that rope being tightly wound together, that tightness gives the strength to the cornea so that it can withhold the pressures inside the eye and don't bulge forward. When those connections become loose, like the right side of the image, right lower ropes, that spacing and the connections between them is becoming lesser and the cornea tends to bulge out because of the natural pressure in the eye. So there are two major changes which happen in keratoconus. The cornea gets thin, as we saw in that image, and starts to bulge, which we call as ectasia, or basically getting more bulgy irregularly. As you can see the screen, and the right lower part, you see that image over here when the cornea tends to bulge in the lower part, in the middle part over there. So this change basically leads to one major result, that is the poor quality of vision due to this irregular astigmatism, or basically astigmatism is nothing but shape irregularity in the cornea. So when it is too irregular, glasses won't work, as you can see this image. If this is how a patient with keratoconus actually looks at the letter A on the biggest chart, you can still see the A, but the halos around that or the shadowing around that makes it unsafe for him to drive or work. Let's look a bit in the history of how long have we known this disease. We know keratoconus since last 275 years. So we have known that this disease exists for a very long period of time. Nothing much was done till we got the use of contact lenses proposed for keratoconus 135 years back. About 100 years back, we thought that keratoplasty, or change of cornea, could be an option. And again, this was the standard of treatment till about 25 years ago when Jeroen Rabanowitz, he passed away recently, rest in peace, he proposed the criteria of trying to pick up keratoconus early, which was not much useful till we actually got a treatment to prevent cornea from getting worse, which was introduced by Theo Seiler in 2003 in Germany and Switzerland, when we introduced this concept called as cross-linking. I'll talk a bit more about that. But the important takeaway from this slide is that it is not a new disease. The incidence has been increased. We see more cases because we pick them up earlier right now. And we pick them up earlier right now because there is a valid argument for treating this disease early because it's progressive and cannot be reverted back again. And I'll talk more about that in the next few slides. So let's go back to a scenario 20 years back when we did not have cross-linking available. A young patient walked into the clinic, and this is a time when we were kind of starting our new attending jobs at the time. So a patient walks into my clinic with early keratoconus, and the discussion went like this. I would say to him, hey, I have some bad news for you. You can use glasses and contact lenses, and unfortunately, there's nothing else we can do for your eyes, and you might eventually need a corneal transplant, which is a big deal. In the most likely scenario, the disease will keep on progressing because you're young, and you might need a transplant in future. That's a very likely yes, if we don't, because we don't have anything to come to control it. Now, since we have cross-linking for the last 20 years, and cross-linking is FDA approved for the last 7 years approximately, young patient with early keratoconus walks in the room now, we can tell them we still have a bad news, but we can take care of it now. And instead of the cross-linking being the end, the corneal transplant being the end all, we can actually do cross-linking and prevent you requiring a corneal transplant ever in a large majority of patients. So we can stabilize the disease, and we might not need keratoplasty in your eye at all. In fact, one of the largest indications for keratoplasty or corneal transplant in a young adult was keratoconus before we had cross-linking. And since cross-linking has come up, the amount of patients who are young and are undergoing transplants have fortunately gone down much lesser right now. So let's look at the life history of keratoconus. It's a chronic disease like most of the diseases are. And with time, as you keep on growing older, the disease keeps on worsening. It tends to stabilize when you're in the late 40s or early 40s, depending on where you are from. But obviously, the change has been done so far. So for our understanding, let's divide it into 3 different parts: preclinical, early changes, and late changes. Preclinical changes are changes in the structure of the eye, which can be picked up by a testing which is sophisticated called as biomechanics, and then looking at something called as unique microscopy. There are some genetic risks. We can look at genetic tests which are not very sensitive. Then family history and ethnic factors play a role. People with Middle Eastern ethnicity and Indian Asian ethnicity tend to have higher and more relentless progression of keratoconus. Early changes is when you have changes happening in the shape of the cornea and it is not very manifested. So these patients are generally missed, especially when you are being screened an optometry clinic or an optical shop and they don't know the devices like topography. And we'll talk about topography in the next few slides. And the night symptoms are present at this time. So the patients typically feel that the night vision is still worse. And the late changes are obviously when you miss the bus. The patient is already having advanced keratoconus right now, and you're looking at contact lenses and looking at potentially transplant or sometimes in cross-linking at this point of time. So the goal, which our team has been working on also, is to pick up the first 2 stages and improve the pickup. As we have a treatment now, and as Craig was talking about, our interest is in early detection of keratoconus. So our aim is to pick it up early and treat it early. If we can pick up keratoconus at the yellow zone, or at least in the early white zone, we can treat it over there and we can prevent significant irreversible visual loss, which is the holy grail over here right now. But before that, we should start looking at how we can screen these patients in the community. And this information, even though essential for optometrists and optical practices because they're the first point of contact, it's also important for the community to know. If you have a young adult or a teenager who has worsening halos and glare in night, that means he sees lights and streaks along the eye, which is getting worse in the nighttime, or his night vision is typically getting worse, or they feel that there is double vision, or there's a rapid change in the glass prescriptions, or they rub their eyes quite a lot. These are the 5 warning signs we should look for, and we should subject these candidates to further screening, testing to make sure that we know they have keratoconus or not. Okay, not all those patients will develop keratoconus, but some might be having that. So that comes to the point, what is testing? So the gold standard for testing something is called as corneal topography. It comes in various shapes and sizes, and we'll cover the basic ones over here. So what is topography? Basically, when you're trying to look at the cornea, look at the image on the left side, the circle over there in the center, that is what normal testing looks at. That testing might actually miss any pathology, which is shown in red in the scan over here because it is too central. So once you look at the shape of the cornea outside that black circle in the center, and you try to look at, talk about this black circle over here, if you look beyond this black circle and you look beyond outside the eye, outside in the rest of the cornea, you can actually pick up changes, and then that becomes much more easier for us to analyze. So keratoconus basically starts outside the central cornea, and therefore these basic testing such as refraction keratometry can actually miss it. Now, this is how typical topographic images of keratoconus look like. And I mean, You can have friends or family members who will have these scans being done, and you can look at these images. This is for an optometrist and an ophthalmologist to detect, but obviously as a patient, they should know that these are the changes which we expect on the eye. And this is a wide range of normal, and there's a wide range of abnormal over there, but a normal topography scan can actually give us a lot of information. So once we know the diagnosis, let's look at the treatment options we have for keratoconus. We'll divide this into 4 parts. Anatomical progression, that means actual worsening of the disease. How do we manage that? How do we manage the vision? How do we make the patient see better? Corneal transplants, when do we need them? And other treatment scenarios which are experimental, so we don't do them right now. So let's look at anatomical progression management. The first part over there is to look at reducing the risk factors. That means rubbing the eye should be avoided. Eye rubbing does not cause keratoconus or may not cause keratoconus, but it can definitely cause worsening of keratoconus. Another important factor is obstructive sleep apnea. If somebody has sleep apnea, that has been shown to be associated with progression of keratoconus. Eye allergies need to be treated because eye allergies can cause rubbing, and as we know, eye rubbing can cause keratoconus. For patients who are less than 40 years of age, we generally recommend screening at least once in a year for patients with known keratoconus. It can be more frequent than that, but at least once in every year. And later, when you're older than that, based on how you're progressing and what's the pathology, that's kind of a bit more nuanced. And if the patient is worsening, we do corneal cross-linking. So cross-linking is something which is very interesting. So we'll talk about that next. Basically, cross-linking is a catalytic process. We use riboflavin, which is a vitamin, put drops of riboflavin on the cornea, shine UV light on the cornea, and that increases the strength of the cornea by increasing the bond between the collagens. I'll show that in the next slide. It's an outpatient procedure. It takes about an hour, and it's done under topical anesthesia. That means you don't need to be put to sleep. You're conscious and you don't feel anything. It's just being light shine on the eye. There's no laser actually. It's just UV light. It makes the cornea more stiffer, as you can see in the diagram over there. The normal cornea is on the red side. The strength, the higher the bar, the strength, more strengthened it is. The green one is how the cornea changes when you cross-link it, and yellow is how a normal keratoconus cornea becomes open. So the point where at this age, when you get the cross-linking done for the patient, at this particular time, the strength increases and the strength stabilizes much more. Even though it's not reaching the level of a normal eye, it's much more to prevent any further progression. Now, as you can see over here, we talked about the ropes in the slide some slides before. These red bonds over here are actually the connections between the collagen. When you shine that UV light and then you shine and you put in the riboflavin, that increases the amount of collagen you have, and therefore the amount of cross-linking between the cornea becomes more, and the cornea becomes more stiff and stronger. This process has a 2-stage outcome. You can see that happening immediately, the stiffening, and then it goes on happening for a year or more. After cross-linking, then we have this algorithm we follow. If your vision with glasses is good, we just give you glasses and let you be with that. If you still have a lot of double vision, or you don't want to be free of glasses, you want to reduce the dependence on the glasses, there's a treatment called as ICL, or implantable collamer lenses, which is technically off-label for keratoconus, but still can be done. Then other than that, if we go to the other side of the spectrum now, if you look at patients who do not have good vision after cross-linking still, because we don't expect cross-linking to improve vision, stabilizes your cornea, we give them contact lenses, which are specialized, and let them adapt to those contact lenses. Now let's come back to the second option, vision management. As we talked about contact lenses briefly, a unique thing over here is if you have early keratoconus, we can actually manage with glasses and normal soft contact lenses. That works very well in early keratoconus, and we don't have to worry about that more furthermore. But in patients who have advanced keratoconus, as you can see in the image on the line diagram on the right side, the irregularity of the cornea is not compensated or not managed well by help of using glasses. And therefore, the image formed at the back of the eye is very irregular. However, when you look at putting on a contact lens on the eye, it actually acts like an artificial cornea, as you can see in the image on this side over here on the left. And the image focuses much better. So patients see much better by using contact lenses which are specialized for keratoconus. And that quality of vision is much better than what you can get with glasses. And therefore, that becomes the standard of treatment. And we have an optometry team with us we have got two very talented optometrists who are working with us right now on specialized contact lenses. And most of our patients go back and forth between them The medical part are covered by me and Dr. Jhanji, and then the optical part are covered by them, and we kind of work as a team together so that you don't have to go outside and look for contact lenses. Finally, if we are at a stage where we cannot do contact lenses because the patient might be intolerant to contact lenses, have severe allergies, or there's a scar in front of the vision which is blocking the contact lens to function, we can do a transplant, which can be done in two different ways. The first part is called as a partial thickness transplant, in which you leave a small rim of the cornea back on the down, and then you put a healthy cornea on the top of that. This is when you don't have a scar at the back of the cornea. If you have a scar at the back of the cornea and then you cannot leave this safe rim over there, then do a full thickness keratoplasty, in which you move the entire cornea and put a new rim over there. Having said that, keratoplasties, as we talked about, are our last resort right now, because even though the success rate is fairly good, it's an invasive treatment. So as long as we can prevent the need for keratoplasty by a combination of using cross-linking and giving optically useful contact lenses, we have a victory over there. And that's where the hope comes in, the story of despair and hope, which we talked about initially. So this is a summary of what we talked about. 3 points: anatomical progression, vision management, corneal transplants. Again, anatomical progression, reduce the risk factors, take care of obstructive sleep apnea, manage the allergies, monitor the patient regularly, cross-linking if needed, glasses and contact lenses. And if you're contact lens intolerant or there's any other issue, we can obviously do a transplant for you. On that note, I will switch over to Dr. Jhanji.
Well, thank you, Dr. Prakash. That was a very nice overview. Craig already gave an introduction. So I'm Vishal Jhanji. I'm Director of the Cornea Services, and I'll talk a little bit about what does the future hold. Fortunately, in that story from despair to hope, we are, it seems, moving towards certain hopeful things in near future. And we do appreciate the help from our patients. Everyone who comes to the clinic is actually helping us. By just you being a patient at the Vision Institute, at the Department of Ophthalmology, are helping us to understand this disease better. Every time you come in, we do certain things. We take images, we think about certain treatment modalities, and then some of you are kind enough to participate in ongoing clinical trials as well. So I want to thank everyone who's here, and also anyone who's going to take a look at these slides later on. So this has already been summarized by Dr. Prakash. Things were different 10, 15 years ago. We didn't have much. But now, contact lenses, transplants, additive technologies. So all these have really improved the outcomes of keratoconus as a disease. I remember as a resident, we used to see patients who were in their 20s. And when I moved from one country to another during my training, the age range, it became larger. And as Dr. Prakash mentioned, most of that is attributed to better diagnostic techniques and better treatment modalities. There was a very nice article that was written ages ago by one of my mentors in New Zealand. Why don't we see older patients with keratoconus? And this is about 25, 30 years ago. And the most common reason, unfortunately, was probably they die soon because their vision's so bad. They get into some kind of trouble, accident, falls. That's why we don't have many older keratoconus patients. But I have to say that over the past 10 years, things have changed drastically. So here we are moving towards hope. I really want to, draw everyone's attention to this photograph. This is a patient who has advanced keratoconus, had a transplant, and keratoconus can sometimes come back in a transplanted eye. It takes a minute for us to make the patient realize and for the patients to understand that when we do a transplant, the cornea is about 11 millimeters, almost a circle, not exactly a circle. When we do a transplant, we change the central 8.5 millimeters of your cornea if someone has keratoconus, but the rim still is keratoconic. So you never basically get rid of the disease completely. And in early 80s, people started to realize that if patients have a transplant surgery done at a really early age, they have the rest of their lives, for the keratoconus in that rim to progress further. So these patients are really difficult to treat, but thanks to the new contact lens designs, which are really, really game changers. Now, if you use a really large contact lens, we're not talking about 12, 14 millimeter soft lens that sits on somebody's eye for daily vision. This is a large lens. It sits way beyond where the cornea ends, as you can see in this picture, 24, 26 millimeters onto the sclera. So they give fantastic vision. Researchers in South America, they published a very nice study showing how many of these patients are able to avoid a corneal transplantation if they have a proper contact lens for their cornea. And of course, the pupil doesn't look circular in this patient because the patient also had sort of a complex cataract surgery. But at the end of the day, this patient was quite happy and could drive with a nice contact lens fit. This is just a picture showing a patient who has massive keratoconus that extends from one edge of the cornea to the other edge of the cornea. So in order to encompass most of the keratoconus, sometimes we do have to do a partial thickness corneal transplant, which really goes from end to end as far as the corneal diameter is concerned. And patients do see better, but they still need glasses, or it's even better if they get contact lenses to see better. The problem with corneal transplantation is probably not something that we face here. I always tell my patients, we have to consider ourselves lucky. There is an abundance of donor corneal tissue. Both Dr. Prakash and I, we trained in India, where the wait for a transplant can be up to 2 years, unfortunately. I worked in China and Hong Kong, where the wait can be up to 3.5 years sometimes. But in countries like United States, and I've had a part of my training done in Australia, the wait is hardly a few days. So overall, if you look at the data from around the globe, there's only one donor cornea for 70 people who need a donor cornea. So ultimately, we have to look for options where we can provide good vision to patients without a corneal transplantation. Collagen cross-linking is certainly one way to slow down or stop the disease progression so that these patients can see better with contact lenses. So the future really holds a promise here when we talk about diagnosis of keratoconus. This is some work that we've been doing with some collaborators in southern China, where we're trying to sort of take imprints of the corneal epithelium. The cornea is the front of the eye, where keratoconus affects that part of the eye, to understand the pathophysiology and really understand how inflammation affects the cornea and thereby leads to exacerbation of the disease in these patients. As Dr. Prakash mentioned, eye rubbing has been associated with the progression of the disease. It was only about 10, 12 years ago when keratoconus was considered a non-inflammatory eye disease, which means that if you look at the tear film in these patients, you're not expected to find any inflammatory mediators. But now we know that keratoconus is actually an inflammatory eye disease. And if you look at the tear film of these patients, you will see that there are a bunch of inflammatory mediators which can lead to progression of the disease. And now we also know that eye rubbing really leads to a spike in the amount of inflammatory mediators in keratoconus. We have been working with our colleagues in Duquesne University to make cross-linking better, more effective. There are patients who cannot get cross-linking done because their corneas are too thin. The reasons are multiple. They may not find out that they have keratoconus. They might be living in a place where they don't have access to a cornea specialist. They have been basically told all their lives that they were born with poor vision, and that's how it is. When they come to us, their corneas are very thin, and cross-linking does not work very well or at least it's not FDA approved for now for very thin cornea. So we're trying to sort of make cross-linking more accessible to these patients. This is, of course, a work in progress. We're trying to mix riboflavin and oxygen together before this riboflavin can be used. It's a chemical that is used during cross-linking so that more patients can get access to this treatment modality. My colleagues, actually my colleague, Dr. Gary Yam, who's here at the University of Pittsburgh and runs the corneal stromal stem cell lab, and also our new colleague, Dr. Rizwan from Michigan Tech University, we have been trying to sort of work on certain modalities whereby we can try and see if we can potentiate the thin corneas that are already there in keratoconus. So as Dr. Prakash mentioned, keratoconus is characterized by thinning of the cornea. So instead of doing a transplantation where we have to change the cornea, or collagen cross-linking where we are basically just stopping the progression of the disease, can there be a modality whereby we can actually increase the thickness of the cornea in these patients so that they do not need cross-linking or they do not need a corneal transplantation? This picture here is basically from animal eyes. It represents sort of an experiment, not in keratoconus corneas, not in animals that have keratoconus, but it's a proof of concept that you can add cells and try and take care of the thin corneas and also the scarring associated with thin corneas. So that is, again, something, a work in progress. I want to acknowledge both Dr. Yam and Dr. Rizwan here. So this is basically not the future, but this is something that I always mention. Very few people realize that keratoconus can affect every age group. And again, as Dr. Prakash mentioned at the beginning of his presentation, keratoconus was always there. You know, it's just that with improvement in scanning modalities, we are now able to look at keratoconus and find it and treat it. So we were fortunate enough that our chair, worked hard to get a cross-linking unit for the Children's Hospital cornea department before we could get one for the adult side. And I think it was worth it. Now, we do treat a lot of patients with keratoconus in sort of a very younger population compared to what we do here at the Children's Hospital of Pittsburgh. Progression of the disease is very fast in some of these patients. Of course, imagine a kid who's 7 or 8 years old or 10 or 12 years old with diagnosis of keratoconus, the progression is going to be much, much faster. So some of them would need retreatment of the cornea if they receive cross-linking. Visual rehabilitation is sort of very difficult. You can only imagine how hard it would be to put that large contact lens on a kid's eye. And of course, because they're kids, they're hard to examine. They can be associated complications, but we have a very, very able team of corneal doctors at the Children's Hospital of Pittsburgh that takes very good care of these patients. So something just to keep at the back of your mind. And this is something that is really, close to my heart. I'm a part of the Global Down Syndrome Foundation. Just for everybody's knowledge here, there are certain diseases that are associated with a high prevalence of keratoconus, and Down syndrome is probably very close to the top of the list. And it breaks our heart when we have patients who are in their 20s and 30s who have had Downs, since they were born, and they never had a proper eye exam. And when they come to us, sometimes it's too late for us to do anything for us. So we are working, actually, we just started working with the Global Down Syndrome Foundation to make sure that there is a pathway for these patients to be seen by an eye specialist early in the course of the disease. Everyone with Down syndrome needs to be screened at some point of time by an eye specialist to make sure that we are not missing any important eye diseases. Down syndrome, keratoconus and cataract are the top two. So this is my last slide. I want to acknowledge, of course, our chair, Professor Jose Allen Sahel. Without his support, him and Eye Near Foundation, They have been very kind to support all the endeavors put forth by Cornea team. The picture next to mine is of Dr. Ken Nischel, who's the Division Chief of Pediatric Ophthalmology. We work closely with the colleagues at CHP to take care of patients with Down syndrome. He's a world-renowned cornea specialist and has been very supportive of all our endeavors. And below is a team of our cornea specialists. Dr. Gaurav Prakash is here, Dr. Rohina Kamiar, who works out of St. Margaret's, Dr. Alex Mammon, he's at the Vision Eye Institute, Dr. Deep Dhaliwal works out of Shadyside, and Dr. Sabrina Mukhtar, who works out of Vision Institute as well as St. Margaret's as well. Thank you very much for your attention. Happy to take any questions.
Yeah, thank you both so much for a really great presentation. And I want to piggyback off of your last comments there real quick, Dr. Jhanji, and kudos to you for your work with the Global Down Syndrome Foundation. I just want to say that we are working to get a webinar scheduled later this year where Dr. Vishal, or Dr. Jhanji and Dr. Ken Nischel will be presenting on ocular diseases and vision problems in people with Down syndrome. So I'm going to dive right into the questions here, and Dr. Jhanji and Dr. Prakash, just whoever is best to answer, go ahead and jump at it. So first question is, getting fitted for contacts is very difficult when you have keratoconus. What should a patient look for in an optical office to make sure they're getting the best treatment?
I can take that, Vishal. So obviously there is a skill set required by the optometrist, and there's a specialized set of contact lenses which are required for keratoconus. So like we were talking about, me and Dr. Jhanji were talking about the uniqueness of the contact lenses we use for keratoconus, right? A normal soft contact lens, which kind of molds on the shape of the cornea, will not work very well because, again, you have an irregular cornea, it kind of wraps around the cornea. So you need to have these larger contact lenses, which look large, but with the learning curve, they're easy to put on the eye. These are called the scleral lenses or mini scleral lenses. You need to go to an office where the optometrist who fits these lenses has been trained to those lenses. And there are a few in Pittsburgh and the area are surrounding. And as I said, with us at the Vision Institute, we have got two optometrists who specialize into this very well, Dr. Sanders and Dr. Haroon, who work closely with our team, and we kind of work on that together. But let's say if you cannot come to us and you are outside Pittsburgh or you are looking at another location, these contact lenses are called as medically necessary contact lenses, and most insurances based on their plans do cover them because they are not cosmetic contact lenses. That puts a bit of advantage in the sense of screening, and it takes a few iterations to kind of get the best fit for you. There is in fact a set of contact lenses called as rigid gas permeable lenses, which a lot of patients who are on the older age for keratoconus have been using that before. They work well, but they're smaller, they kind of dangle around the eye. So if somebody starts off with using contact lenses, we generally ask them to go for mini sclerals because the comfort level is much more. Those lenses actually never touch on your cornea, they kind of sit on the top of your cornea. So there's a clear space between the cornea and the contact lens, and that helps from preventing any scarring from happening. So long answer short, you should go to an optometrist who specializes into this specifically, and let them know that I'm looking at medically necessary contact lenses for keratoconus.
Okay. Next question is, I feel that removing my contact with the plunger is putting more stress on the cornea. Can removing the lens with the plunger damage or stress the cornea?
It can, if you are not trained into doing that, because there is a small amount of vacuum which is created. That's how the lens stays on the eye. But having said that, most of the time we have something called as an INR, which is an informational process in which the technician actually teaches you how to use a contact lens, and you can actually dangle on the lens slightly before you give it, as they use the word, give it a little shimmy to take the lens out, and that breaks the vacuum. And that's a problem with most contact lenses, not specifically with the medical necessary contact lenses as such, that they can get stuck to the eye and to kind of break the vacuum before you take them out.
Okay. Do patients with keratoconus have trouble with collagen in other parts of their bodies? For example, would they suffer with very dry skin?
I can tell you that. So a very difficult question to answer, but very meaningful. We don't know much about that actually. And I wouldn't be surprised if someone with keratoconus has something else systemically. here's what we ask our keratoconus patients. And if you are one of them and listening, this is what your doctor should be asking you. Did you grow up with any severe allergies? So that covers your dry skin to a certain extent. Do you sleep on one side more than the other side? Because people have postulated that sleeping on one side, let's say somebody sleeps on their left side more than the right side all their life, and their keratoconus happens to be worse on the left side, that might not be a coincidence. Have you been rubbing your eyes vigorously since you were a child? Have your glasses, the script on your glasses, has it been changing since you were in middle school or high school? Do you have any sleep apnea, which Dr. Prakash covered already? So all these questions, they are sort of pertinent for any patient who is looking for a physician who can take care of them and if they have keratoconus or not. So I hope that answers that question indirectly. It is possible that patients with keratoconus, they have dry skin, but that's not a primary association. It's because they have something else going on.
Okay. So somebody asked a question that you already addressed, which is, do children ever present with keratoconus? So I'll kind of switch that question a little bit and say, is there, a common age where they start to show symptoms, or are there any signs that parents should look for at a certain age or anything like that?
Yeah. So again, so in South America, there's actually a screening program. Their idea is that because you live in a humid climate and people rub their eyes a lot, they want to screen the whole population for keratoconus. That becomes difficult. There is a study that was finished in the Maori population in New Zealand about 2 years ago. The reason was they found a high prevalence of keratoconus in these patients. So they screened everybody. Okay. It's difficult for us to screen every kid in the country. And fortunately, we do have screening programs, which are already built into the school system. So if your kid comes back home with a note that they can't see well and they need refraction, the person script for glasses, the person who you're going to see for glasses, a good optometrist, I hope, they're going to tell you if the script on the glasses is a little funny. And based on that, they can send you for a screening test. The youngest patient that I have who is a keratoconus suspect, we've been following up with that patient, is actually 12. But I'm sure if Dr. Nishal was here, he must have seen patients who are younger than that who developed keratoconus. So yeah, kids can develop keratoconus.
Are there any environmental changes that somebody can make who are dealing with keratoconus symptoms to help?
So yeah, if someone is an eye rubber, and there can be multiple reasons for that. It's very easy for us to tell somebody, stop rubbing your eyes, okay? But it's not easy to sort of do it in real life. So we do give patients, if they have itchy eyes, you can use certain over-the-counter medications, preservative-free eye drops. There are certain medications that reduce the itch. So those are some things that can be added to your daily routine. If someone has obstructive sleep apnea and uses a CPAP machine and has keratoconus, they need to make sure that the mask fit is appropriate, because many times these patients will come back and they will actually acknowledge that when they're sleeping, the airflow goes directly into the eye. And when they wake up in the morning, their eyes are really red and irritated. And then, of course, anything that irritates the eye and leads to eye rubbing can cause worsening of disease to a certain extent.
Okay. So you talked a little bit in that answer about the sleep apnea. So I'm curious, obviously sleep apnea has a connection to keratoconus, but does the risk go down if the sleep apnea is properly treated, or is it an internal problem?
So again, as Dr. Prakash mentioned, you can't find a primary association, but you can have worsening of the disease in patients who have sleep apnea. And that is most likely related to a general habitus of these patients, okay? So the most likely reason is that CPAP machine. okay, which is causing the airflow is causing ocular irritation, which can lead to eye rubbing and hence the worsening of disease.
What can we do to make everyday optometrists more aware or more sensitive to keratoconus? In particular, what can a layperson, and in this person's situation, he's a scientist but not medical, what can they do to basically help spread awareness among optometrists about keratoconus?
So that's a very relevant question. And the reason why Dr. Jhanji wanted me to take that question is because we have done a similar initiative back in the place I was working in the Middle East. I was working in United Arab Emirates a few years back before I came over here. It's important for the patients to be evangelists and somebody who has keratoconus to spread the awareness. But like in this scenario over here, most optometrists are aware of the situation that there is a disease called as keratoconus. They know about it, right? Any optometrist should know that a change in astigmatism specifically and night vision symptoms are a risk towards keratoconus. So as long as they know that this could be there, and the screening threshold should be much lower. Obviously, there is a logistic concern, which I think Dr. Jhanji very eloquently put over there. That's very difficult to screen an entire population, especially in younger kids or younger adults for keratoconus. But our primary point of contact almost always is a school nurse or a school optometrist for younger kids, and for grown-ups, the optometrist they go to. So if you find that the astigmatism is changing, if you find that the night vision is getting worse, that's a time when you should get a topography scan done. And there is no way somebody who's looking at a patient with early keratoconus on slit lamp, that's basic eye examination, can pick up keratoconus unless they do a topography. Even we have been looking at keratoconus for about 25 years together. And I don't think that if you bring in a normal keratoconus with me, a very early patient, I'll be able to pick it up on a slit lamp. It's like a CT scan looking inside the structures of the brain. Same way, you need to get a topography to look at these patients and see if they have keratoconus or not. But yes, the screening criteria has to be changing astigmatism, eye itching, rubbing of glasses, and that awareness is spread in two folds. We spread it in the community by talking to the optometrists as much as we can to kind of be mindful regarding this particular disease, especially in a family history. And as a patient, as long as if you know somebody who has keratoconus, if you spread that information to 5 more people and this spread it to 5 more, it becomes correctly expanding. And then that's how the community comes to know about this. I also want to add a point regarding pediatric keratoconus. You're talking about that young patients. I feel that patients who have a family history of keratoconus are the ones who should be screened a bit more frequently, because even though not all cases genetic, if there's one of the parents, or at least one of the parents' lineage has keratoconus, that kid might have a slightly higher chance of developing keratoconus as they grow older. So that could be one screening criteria in addition to what we discussed.
Great, thank you. Can other corneal conditions such as Fuchs disease lead to keratoconus?
Yeah, so Fuchs will not lead to keratoconus. It's a specific gene, but it is not unusual for Fuchs to coexist with keratoconus. It's widely reported, and we see a few patients every year.
Okay. And then we have a research question. Is research testing using stem cells for keratoconus taking place?
Well, too preliminary. The picture that I showed was from a similar experiment, but the concept is still the same. So the idea is, again, as I said, to program certain cells, whether they are stem cells or not, to go and reside in these corneas, so that these corneas can become stronger, if not thicker. Biomechanical weakness is one of the main problems in keratoconus. And of course, that would have been too technical for this talk. So you're looking at a weaker cornea compared to a normal cornea. So imagine adding some cells to that cornea and making it stronger, maybe stiffer as well. Cross-linking makes the cornea stiffer. So we are trying to find ways to make it stronger as well. I hope I was able to answer that to a certain extent.
Okay, and that's actually the last question that we have. So I'll just close by thanking you both again for joining us and giving such a thoughtful and insightful presentation on what's going on with keratoconus and what's going on in our department with it. So to everybody who joined in, thank you again for joining us today. We'll be having our next webinar in 2 weeks with Dr. Libby Smith, who will be giving a presentation about preserving your voice as you age. So I hope everybody has a great rest of your day, and thank you again for joining us.